Good afternoon. My name is Matthew Clay, and I'm with JBS International. Thank you for joining us for today's webinar, Highlights of the National Strategy for Maternal Mental Health. Before we begin, I'd like to review some housekeeping items. Due to the high number of participants on this call, all participant lines will be muted for the duration of this webinar session. If you have any comments or questions, please submit them at any time by using the Q&A window. To open your Q&A window, please click on the Q&A icon that's located in the bottom center of your Zoom window. Closed captioning is also available. To turn on closed captioning, click the link that's located in the chat. If you experience any technical issues during this webinar, please message us using the chat feature, which is also located at the bottom center of your screen, or you can email us at samhsastateta@jbsinternational.com. Lastly, this is a recorded event, and your participation grants consent to be recorded. The recorded webinar and PowerPoint slides will be made available and shared with participants at a later date. Next slide, please. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. Next slide, please. At this time, I will introduce our presenters for today's webinar. Nima Sheath is a psychiatrist by training with a strong public health background. Prior to her arrival at SAMHSA, Dr. Sheath worked at Georgetown University Hospital as assistant professor of clinical psychiatry. During her time there, she served as clinician, researcher, and educator, primarily focusing her efforts on improving care of the critically mentally ill and highly traumatized populations, both nationally and internationally. Currently, Dr. Sheath serves as a senior medical advisor at SAMHSA's CMHS, the associate administrator for women's services, and chair of the advisory committee for women's services. Dr. Sheath is also the SAMHSA point of contact on the new Maternal Mental Health Task Force. In addition to leading women's mental health issues at the agency, Dr. Sheath also specializes in refugee and migrant mental health, implementation science, diversity, equity, inclusion, and accessibility in the behavioral health workforce, and leads the center's technical assistance efforts. Madonna Green is a public health advisor at SAMHSA's CMHS. Her work focuses on women's behavioral health. She is a clinical social worker with over 15 years of experience. Throughout her career, she has provided direct services and served in leadership roles in nonprofit and government settings. She's led teams both clinically and administratively and strengthened the systems and processes in her focus areas. Madonna earned her MSW from Howard University, which set a strong foundation for her career. She's worked with sexual violence survivors, provided clinical services to families achieving permanency within the child welfare system, and worked in compliance for public behavioral health services. I will now turn to Dr. Sheath and Madonna to begin today's presentation.
Thank you so much, Matthew. It's such an honor to be here with you all today. Today, we're going to go over some of the highlights of the national strategy to improve maternal mental health that was released by the task force on maternal mental health back on May 14th. For the next slide. So this task force was established through congressional language, and it calls for SAMHSA and the Office of the Assistant Secretary for Health to co-chair this together. So the co-chairs are Admiral Levine and Dr. Dalton Whitman. The purpose of the task force is to make recommendations to coordinate and improve federal activities related to maternal mental health that includes substance use disorders. So we've been using the term behavioral health to make sure that we are covering both mental health and substance use. And also, to the extent possible, making recommendations around the intersection of mental health, substance use, and gender-based violence. And it's about improving federal coordination, but also about improving the state of maternal mental health writ large, identifying best practices, figuring out how we could partner better with states, with non-federal entities, to make sure that we have a global look at the landscape of maternal mental health, out inside federal government and outside federal government. Some of the do-outs of the task force include an annual report to Congress, which we also released back in May 14th of 2024. We will talk through the highlights of that report as well in just a few slides. To release a national strategy to improve maternal mental health. That was technically due this year in 25, so in the second year of the task force. However, we were very ambitious and got it done in the first year. So we released both the strategy and the report to Congress early on within the first year, so that we could prioritize implementation here within FY25. It also calls on for a report to governors to be developed, and we would like to hear back from you on that. That's something that we're looking at completing next year, but really looking at continuing to meet with state partners and hear from states. We have a number of initiatives with states that we want to capitalize and learn from, and want to continue to partner with to look at formulating the report to governors. And it also ensures that we solicit public comments from stakeholders for both the report and the national strategy, which was done through an RFI. We also held a number of listening sessions with various local government and state-based entities to create both the report to Congress and the national strategy. The task force is set to sunset on September 30th, 2027, although we have called for extending the task force and turning it into a coordinating committee in Pillar 1 of the national strategy, which we'll also talk about. Next slide. So this is the task force timeline. We have the official maternal mental health task force launch in September 2023. And you can see between September and May is when we did all of this work around the report to Congress and the national strategy, to give the task force immense credit. And my colleagues here on the call, Madonna Green especially, they organized over 40 meetings to complete this strategy and report to Congress. So it's just an immense effort, lots and lots of collaboration across federal government and outside of federal government as well. So I won't read all these, but you can kind of see the different processes that happened, and we'll talk about the structure of the task force and how decisions were made shortly thereafter. So we can go to the next slide. So this is a little bit about the structure. So the task force home is under the Advisory Committee for Women's Services, which is a Federal Advisory Committee, or a FACA, that is within SAMHSA. And we created a subcommittee of that FACA where the task force is actually, being held or kind of executed through. So the task force itself is the subcommittee, which then consists of over 120 members of federal and non-federal experts. And then the task force subcommittee was further divided into 5 work groups into the following focus areas. So data research and quality improvement, prevention, screening, and diagnosis, evidence-based intervention and treatment, evidence-based community practices, communications and community engagement. And we use the term evidence-based for shorthand here to be representative of evidence-informed and promising practices as well, and to really strongly be considerate of adapted evidence-based practices. So in the congressional language, they do actually use evidence-based, evidence-informed, and promising. So there remained that focus from our task force and our experts on all 3 of those terms. And then the scope in this first year of the task force consisted of the perinatal period, which we defined. We use the definition of during pregnancy and up to 1 year after. And like we said, it does include both mental health conditions and substance use disorders. Next slide. This is just a slide summarizing the Advisory Committee for Women's Services. We just want to point out and thank the members of the Advisory Committee for Women's Services, a majority of whom serve on the task force, and out of those also volunteer to be co-chairs of our various work groups, which is not an insignificant amount of work. So, and they're continuing this year as well. So we're very privileged to have their continued involvement. Next slide. This is a list of the participating federal agencies. I think the thing to point out here is how collaborative this has been. You see there's various agencies across Health and Human Services, but then we also get into, departments outside of HHS. So Department of Defense, Department of Labor, and, the OMB, the VA, we have IHS, we have lots of collaboration, across the board. So it's really a heroic story of collaboration coming together with a lot of hard work. Next slide. The task force work group co-chairs are listed here. I won't read through each one, but you can see each work group has a federal and a non-federal co-chair. Next slide. So we just want to mention here that the work of the task force has been built upon existing work in the federal government and tons of work outside the federal government, all of which we have not listed, but we did want to highlight a few existing programs, relatively new programs that the task force is capitalizing on and wants to continue to elevate. I think what's also not here are the two new programs that SAMHSA has come out with just this past fall. One is the Women's Behavioral Health Technical Assistance Center, and another one is a community-based maternal behavioral health services program that will be a services delivery program. Next slide. So these are some of the highlights of the report to Congress. There's about 6 chapters, and the first one is talking a little bit about an introduction on the task force, the subcommittee's findings, background, and methods. And then really in section 3 is when we get into best practices. So Congress in the language asked us to identify best practices across many different domains. So prevention, screening, treatment, community-based interventions, multi-generational approaches. And so the task force was asked to highlight their top 3 to 5 best practices that they would want to include. So it's not necessarily a comprehensive list of all best practices, but the ones that our experts really wanted to highlight and put forward. And they're organized by those different domains that were outlined in the report to Congress. Next slide. Section 4 is a really interesting chapter, also organized by these different domains of prevention, screening, treatment, intervention, and goes through all very comprehensive list of all of the federal programs that exist around maternal mental health and substance use. So it is a very good reference chapter if you're ever looking to see what exists within the realm of federal government work. And then section 5 is one we're really proud of. That we had 4 listening sessions with state and local partners. And this chapter then discusses the overarching themes of those listening sessions that we had. It really just gives a flavor of probably the work that will go into the report to governors. That will be a much deeper dive with our state partners. But we wanted to make sure that we had some of that incorporated as soon as possible. And I should say there's several learning communities and initiatives and collaboratives happening across the board on maternal mental health with states and this work. And you all have been doing this work for ages. So, this is just the work of the task force that's building already on pre-existing work. And then we have the conclusion in chapter 6. Next slide. Okay, so we're gonna take a closer look at the national strategy. Next slide. So this is an overarching, the image that kind of captures all of our pillars. So our strategy has been divided into 5 different pillars. And so each of those pillars are listed here, and we're going to take a deeper look at each one of those as we go on. And at the top, we have our whole person and dyad, perinatal mental health and substance use care. We do want to keep a focus on dyadic care throughout as much as possible. So that has been, you'll kind of see that throughout the strategy as you read it. The terms on the outside here are cross kind of sectional themes that kind of run across the strategy that we asked the task force to keep a priority on. Next slide. So the vision of the task force was really, and of the strategy in particular, was to ensure that perinatal mental health and substance use care in this country are seamless and integrated across all settings, and that we really start to not have a distinction between mental and physical health care, and that models of care and support are going to be innovative and really specific and sensitive to individuals, culture, and communities. Next slide. So the audience is the federal government, which is, Congress, the executive branch, and the myriad of federal departments and agencies that we had mentioned that are part of this, and even ones that are not part of the task force. However, we note that, this work cannot be done in a vacuum, just in federal government, and hasn't been done just in federal government at all. In fact, many and most of the experts are outside of us, and we very much recognize that that work cannot be done without a lot of those private, public-private partnerships, state partnerships, industry partnerships, advocates, medical professional societies, communities, and of course, individuals with lived experience. And so you'll see there's a whole pillar on individuals' lived experience. We've made sure that that remains a focus as we go on throughout this work. Wherever possible, we try to talk about when there's a particular agency that we're calling out or a particular program. And when we don't, it's implied that it's a whole of government approach. Next slide. Okay, so now we get into pillar one, and what we've done is we've left all the recommendations up there for you to reference so you can kind of see the rest of the context that the recommendation falls into. But we won't go through each one in detail for the sake of time today. We'll go through the ones that are bolded here that are the most relevant to you all. So we'll go to the next slide. So pillar one and priority one are all about building infrastructure and national infrastructure. So this first priority talks about promoting integration across the board and really having multidisciplinary and interdisciplinary teams that would then manage and oversee integrated care. So our first recommendation here, we do think applies to states, of course, and it is to build, integrated perinatal and mental health SUD care across the board, starting in pregnancy, pre-pregnancy, all the way through at least 1 year postpartum, including 2-generation care and practices. And then the second recommendation here is to enact federal laws that require the implementation of 6 months of paid family and medical leave and universal child care. And we would want this, to be modeled federally as well as in all states and territories. Next slide. So a continuation of priority 1.1. So the third recommendation here is to establish policies and at whatever level and however possible to support non-stigmatizing and non-punitive approaches to screening and treatment for all of these conditions in the perinatal era, because we know often that punitive screening and treatment has even led to family separations, unnecessary family separations, that there isn't a distinction between mandatory reporting and notification enough. And especially for state to state, the implementation of plans of safe care vary. And there is some standardized guidance, but it still seems like the implementation of those plans and the training around that could be improved. And recommendation 1.1.4 here is to invest federal funding to create family-friendly healthcare facilities across the spectrum of inpatient to outpatient and ensuring free and vetted childcare. So we would want states and other entities and local hospitals to try to model this as much as possible to have spaces for childcare while parents are getting treatment. Next slide. So I'll just spend just a couple seconds on this. So priority 1.2 is to establish and enhance federal policies that promote perinatal mental health and well-being with a focus on reducing disparities. So this is not to say that there isn't any work or partnerships around states, but for the sake of time, we'll have you come back and look at these in the full version of the strategy, but we'll continue on to the next pillar to discuss the next set of recommendations. Next slide. So pillar 2 is making care and services accessible, affordable, and equitable. Next slide. So our first priority within pillar 2 is to is kind of all about screening and linkages and education. So we want to, across the board, establish comprehensive pathways to improve culturally relevant and trauma-informed screening for the presence and assessment of risk factors related to developing perinatal mental health conditions. And again, like I said, we include substance use disorders, and then GBV trauma and social determinants of health, along with the provision of preventative resources, referrals, linkages, and education. Next slide. So recommendation 2.2 here under priority 2.2 is to improve federal funding and support for implementation of integrated crisis intervention services for perinatal populations and their families. And this is our primary recommendation on crisis services. And it touches on crisis service workforce and training, infrastructure development, and implementation. And this one really does require the support of state and local crisis systems and partnership. So more to come on that, and we'd love to hear from you on this one. Next slide. So under, again, priority 2.2, this next recommendation is to work with states and all payers to help establish financial incentives, including increased reimbursement and support for perinatal mental health and SUD interventions that demonstrate positive outcomes. So this is talking about one across the board, improving reimbursement, especially for things like Medicaid. I should have said at the beginning, each of these recommendations has a why section that explains the rationale for why this particular recommendation was chosen over others, and then how and why it's beneficial to the population and how it would change the landscape. And then there's a how section right after that kind of starts to lay the roadmap for how to obtain this particular recommendation. So in the how section, you see lots of more concrete examples of what we mean by this recommendation. So for example, in this one, we have alternative payment models listed. So the TEMA model that's coming out of CMS, but also some of the state developed models that have, alternative payment models that have been developed, call for partnership and support with state developed models, and CMS support for those models, and vice versa. So there's things like that are mentioned, and then incentives, examples of incentives that could be given to increase reimbursement and reduce burden on providers in order to help incentivize them also taking more insurance as well as Medicaid. Next slide. So priority 2.3, this is all about building capacity of the workforce. So we talk about training, expanding, and diversifying the perinatal mental health workforce. Our second one here talks about educating future and current clinical providers in perinatal mental health conditions by ensuring that those topics are included in the curricula for healthcare and mental health care providers. So as we look at allied healthcare programs and non-allied healthcare programs at clinical and non-clinical jobs, such as community health workers, doulas, we think about uniform curricula and education that should be part of all of this, by both modeling it within the federal government, but also partnering with those entities locally to figure out how we could support that. Next slide. So again, here in the workforce priority, to fund, incentivize, and bolster recruitment and training efforts to expand and diversify the perinatal, clinical, and non-clinical mental health workforce. So this talks about taking all of the workforce programs in federal government and bolstering them, increasing funding, expanding them, being able to fit more in for their funding opportunity if it makes sense, if there's appropriate funding to add more services there or add more trainees, but then also calls on partnerships with state and local government to do the same. So any of their existing workforce programs to increase the funding and bolstering recruitment. Next slide. So pillar 3 now is all about data and research and accountability. Next slide. So priority 3.1 is to use data and research to support strategies and innovations that improve outcomes So the second recommendation here is calling on a number of things. So one is to kind of rebuild the trust with various communities who have experienced abuses when participating in research and data collection efforts and are past or currently who continue to suffer abuses, and a number of unfortunate abuses are outlined in the why section of this to document the history and the rationale for calling this out in particular. It also calls on pregnant and postpartum people to be part of research and to invite them to research if they felt called to do so, if they felt that was the appropriate decision for them, for themselves. It's a recommendation that's in line with the U.S. Preventive Services Task Force as well as the CDC. Of course, though, with the kind of highest regard for confidentiality and ethics, and understanding that this is a vulnerable population. So that's what that recommendation is. And again, would want that to be modeled across federal and state government. Next slide. So here, recommendation 3.1.3 is talking about integrated data systems and data sharing across healthcare and community-based services, and using more of that data to drive the development of policies and practices that improve outcomes. The next one is talking about investing in current perinatal health data collection and creating a central clearinghouse of information so that providers, government officials, public health officials can quickly identify and use resources for perinatal health data. So again, these are all ones that would really require heavy levels of state and local partnership. Would want to get a lot of recommendations on existing models that might exist to scale up, and or if a central clearinghouse was built, how we would ensure that state and local government and partnerships were well represented there, and that the data would be accessible to states as well. And the fifth recommendation in this bucket is around creating mechanisms to pair implementation guidance and dissemination strategies with research and scientific findings. So this is that, it's not that if a study were to come out saying, okay, there's a new drug, that's really effective for postpartum depression, that it doesn't just go out there into the ether and it falls on providers to kind of figure out how to dose and how to utilize this drug and what the risks and benefits are, but that there's real implementation support from technical assistance centers, state-based, technical assistance entities that provide implementation guidance and appropriately disseminate that research so that it gets into the right hands and benefits everyone equally, especially because we know there's such disparities in treatments accessibility across our nation. Next slide. So this priority is all around accountability. And the first one here is all about quality improvement. So it is to establish and implement more quality improvement metrics or improved quality metrics for providers, hospital systems, and insurers, and then have multi-year longitudinal tracking of costs and outcomes. And the next two are, one is around perinatal quality collaboratives, just to make sure that they continue with their good work and that they get expanded into all 50 states, DC and US territories. And then 3.2.3 is to continue to fund the maternal mortality review committees across the board. Right now, these do exist in all 50 states. So we just felt strongly that we wanted to make sure that we called out their continuation across time, over time. Next slide. So we're in the fourth pillar now, to promote prevention and engage, educate, and partner with communities. Next slide. So we'll just, point out some of this is that, under this priority, there's only one recommendation, but it is around promoting practices around community level detection and primary prevention, and ensuring that Medicaid and private pay commercial insurance covers these prevention practices. So we do call out a number of different programs like PrEP and centering pregnancy that have been proven to have positive preventative outcomes, and just making sure that those are adequately covered. We also call on adapting certain other interventions that have been helpful in other spaces, like the hair model, that have been kind of the level of community level detection, to see if we can adapt those and bring those over into the perinatal mental health space. Next slide. So again, I won't spend too much time on this one, but priority 4.2 then is about building kind of national campaigns and engagement opportunities with various communities. So again, not that there isn't, it's absolutely a role for states here, but we are prioritizing kind of where we would, the recommendations that we think, fit best with your all's roles right now. But all of these we think have a state-based component that we would love to partner with, federal government and state partnerships, prioritize those partnerships wherever possible. Next slide. Okay, so pillar 5 then is all about lifting up lived experience. So I'll just say this section was really supported by our USDS colleagues. They did a research sprint with a number of individuals with lived experience, as well as practitioners that included mental health providers, but also midwives and doulas. And if you read the report to Congress and the national strategy, you'll see that there's direct quotes from this research sprint to support many of the recommendations and strategies that are outlined in both documents. And then they put together a list of recommendations that kind of summarized all of the different points that were brought up in the research sprint. So here's a little bit of a summary of their perspectives. Continue to focus on care for mothers. They often said that a lot of times immediately the focus goes to the baby, and there's not, the attention comes off mom very quickly when she might not be doing well. Building trust, and then understand mothers as people and what is happening in their lives, respond to the needs of mothers and their families. We can go to the next slide. So in the second priority, we have here to actually not just have folks with lived experience at the table, but really make sure that they are being heard, which is why I wanted to make sure that folks with lived experience and the lived experience component was an actual pillar of the strategy, and we want it to continue to remain a pillar of the strategy at all times. So there is a list of all of their recommendations, and I believe if we go to the next slide, you'll see how their recommendations actually match up with the recommendations and or priorities of the task force. So that was not done deliberately. We took their recommendations and we saw the task force recommendations, and they very beautifully happen to align, which we're not surprised at all. But we do have, if you have a chance to look, a chart that organizes and maps how those two have aligned just naturally on their own. And just give folks a minute to kind of look at the slide. I won't read it all, but you'll see a lot of overlaps with everything that we've mentioned already. Next slide. Okay, so what do next steps look like for the task force? So this year, FY25 is really focused on implementation planning. So what that looks like is, well, an implementation planning and implementation, we should say. So it looks like first getting a sense of what is being done already, what continues to be done that continues to track with the recommendations that are in the strategy. So we have created a tracker that has action steps, current activities, timeline. It's pretty comprehensive, that will take a look across the board, both within federal government and outside of federal government, what is being done already that's furthering these recommendations. And then we are asking our task force to then look at their top couple of recommendations that may require new activities to be implemented in order to obtain that recommendation or get closer to that recommendation. So we are then also collecting those items, on this tracker and working very collaboratively across all of these different groups that have been mentioned to figure out how we can best get to those particular action steps to get closer to these recommendations. We are also know that some of the recommendations will require congressional action, some will require federal agency action. And so we may have a different pace for a number of the recommendations depending on what is being asked, right? Some of them are very hefty recommendations that we're not looking at a year's time for them, right? It's more long term. Some of them are lower hanging fruit that can be done right away. So that's what implementation is looking like. And then, as I mentioned, we have the congressional language calls for a report to governors after an update of the national strategy and report to Congress are completed. So this year we'll do updates of the report to Congress and national strategy, and the following year or following months we'll do a formal report to Congress. The updates could be a change in scope. It could be retaining or revising or editing recommendations. It could be, adding new recommendations. It just depends on what the task force deems appropriate. While we're not doing the report to governors this year per se, we are still wanting to continue to have many, whether it's listening sessions or opportunities to collaborate with states and state partners to ensure that we are still working with them with you all along. We don't just view a report as a one and done or one-time thing. We think that this work has been joint all along. We want to continue to do that all along. So in the implementation planning and implementation phase, there's going to be that focus on state and local government as well. So that's something we very much want to keep in mind. And we'll potentially have another RFI or more opportunities for public input as well as we go on. And I should say there's a number of state-based learning communities. So our Center for Mental Health Services has one with states that's at the tail end now on maternal mental health. And then our Center for Substance Abuse Treatment is hosting another one with states. I think they're about halfway through theirs. And Centers for Medicaid and Medicare is also about a third of the way in. They're about to start their learning communities with states. We had their webinars over the summer and they're starting their learning communities in August. So we have all been tracking and working together to think about what are the lessons learned, what are things to scale up, where can we continue? And I should mention, of course, the Secretary Becerra's collaborative on maternal health as well, state collaborative, which has 6 states involved, 3 of which are focused solely on mental health and substance use in terms of their particular objectives. And I think, again, we're working very cross-government to ensure that we are combining the lessons learned and connecting states to different entities across this process. And so we want to capitalize on opportunities like that and continue that type of work together. Next slide. Okay, so I guess, Matt, we'll pass to you, see if there's other questions, and if not, we can go to the discussion.
Thank you, Dr. Sheath. At this time, we will begin the question and answer segment of the presentation. If you've not already done so, please submit your questions by using the Q&A feature that's located on the bottom center of your screen. Our first question: can you talk a little more about the benefits of an integrated perinatal and mental health SUD care model?
Yeah, absolutely. So a couple of things. We know that, with mental health and substance use, often there's a lot of stigma. Unfortunately, there continues to be. And so one primary benefit is that it does help reduce stigma, because folks can often come to see their primary care or their OBGYNs, where they can get screened for these things and mental health and substance conditions, and hopefully receive care immediately without feeling like they need to come to a specialty behavioral health clinic. That's one benefit. The other benefits are, if it's integrated and co-located, it's just a lot more convenient for patients and especially for moms and families that we know are often struggling with balancing many other things in their life. And so they can get it's a more one-stop shop. It's better care in terms of communication and collaboration between providers. So there's a better sign out. There's less mistakes. We know that evidence shows us when there's an improved sign out, there's less mistakes that happen as well. There's no faxing of reports. A lot of times they're the same EMR system. So I could probably go on for this question, but it's there's a lot of benefits, and evidence has shown that it has worked in a lot of places, namely up to the collaborative care model is primarily is a good example. That's an evidence-based example of integrated care. We have care manager at the center that sits within a primary care clinic and does a lot of the initial screening and management of mental health cases, and then brings on mental health specialists to provide recommendations to primary care. But for all intents and purposes, it's pretty integrated, and it's usually within one electronic medical record, and that system has been shown to be helpful. So I'll pause there.
Our next question, related to Pillar 5, lifting up lived experience. Can you talk a little bit more about the importance of lifting up individuals with lived experience?
Yeah, absolutely. I mean, we know that our healthcare systems, unfortunately don't have a lot of places for patient voice, right? And the way that the kind of, I think it's almost like a pressure cooker, the way we have to function, right? Providers are rushed, everything is rushed. It's, lots of third-party interventions, insurance companies, pharmaceutical companies, determining a lot of what we do and where we go. And it almost seems like everyone gets listened to, but the patient at the very end. And so we know that the patient experience is incredibly vital and important and should be at the center of our healthcare system, right? So we sure are really trying to design things more in a patient-centered way. At the end of the day, we have all these services, but if patients aren't willing to come in, then what's the point, right? So it's the lived experience piece is really at the heart of all of this work and at the heart of the healthcare system. So to make sure that we are kind of patient-centric versus provider-centric or profit-centric or things like that, both of which seem to be the case at this point.
Our next question. For individuals who are interested in learning more about maternal mental health, whether that be learning opportunities, research, programs, where would you recommend those folks go?
Yeah, I guess I'm assuming if you mean clinical education on maternal mental health. Okay, so if it is more, because if it's public health, I think it'd be one space. If it's more clinical, it might be different. But there's a couple of different resources. First of all, HRSA has 12 psychiatry access lines in 12 states, perinatal psychiatry access lines that provide consultation to providers. So that's definitely one good resource. There's also a national curriculum for reproductive psychiatry that is free and out there that provides a lot of pharmacological guidance to providers and training. SAMHSA has a couple of programs. The provider support clinical system, they're all in our technical assistance tab on our website. So those are all, again, free and accessible and have a lot more resources on substance use. And then the last place I'd mention is PSI, Postpartum Support International, actually provides a certification on perinatal mental health. If a provider was interested in getting certified, certification should not be a barrier to providing treatment to perinatal populations in any way. You do not require certification to provide and treat perinatal populations. So, but if one was interested in getting more training, that would be a good place to go.
Those are all the questions we currently have. For the remainder of the presentation, we will keep that Q&A open in case other questions do arise. So Nima, I'll turn it back over to you for the discussion.
Great, yeah. So we had a couple of questions for you all. We'd love some, feedback, and feel free to comment on any one of these three, but if you all have any feedback or comments on the national strategy so far, and then are there things that would be helpful to see in the report to Congress, like things that have been left out or need to be edited or just take a deeper dive into that are more state-based? And any other questions or comments, we'd love to hear from you.
So at this point in time, if you do have a response or comment towards one of the discussion questions you see on your screen, we invite you to use the chat icon that's located on the bottom of your screen.
Okay, I guess we'll go to the next slide. Okay, well, we just want to thank you all. I think we have on the next slide some of our contact information. Go to the next slide. And yeah, our correlates in the Office of the Assistant Secretary for Health and our co-lead, Dr. Dorothy Fink, her contact information is listed, and Dr. Centrise Bellamy as well. We just want to thank, please do reach out if you have any questions, but we are really grateful to have been here and want to thank you so much.
Thank you, Nima. And this marks the conclusion of today's presentation. Just a reminder that all attendees will receive a link to complete a survey following today's webinar. The survey link will be sent via Zoom directly following today's presentation, and again, 24 hours later. We ask each of you to take a few moments to complete the evaluation, as your feedback helps shape future webinars. At this point in time, we'll close up, and we wish everyone a wonderful rest of your day.